thank Saurabh for inviting me to be a part of the faculty on this course. It's a pleasure to be here. And I'm going to take it to the next level, which really suggests that that I'm going to talk about a technique which is a little different from the original divide and conquer. And has been very elegantly shown by Dr. Shroff with those animations. It does tend to give a response in most situations, but there are certain areas where the divide and conquer is probably deficient in some ways. It is an easy technique and it can be used even with a single hand, but the problem is it uses slightly higher energy, takes a little longer time, uses a little more fluid. The phaco chop, which is again the direct phaco chop for the harder cataract, is going to be discussed as well, and that uses much less energy. Essentially, any technique in which we're going to use manual energy in chopping is going to use less energy on the machine. So it's a direct corollary. You're trying to break up a piece of stone, and you can either use machine-based energy or you can use your hand. And the more hand you will use, the less energy you'll use. It's pretty straightforward. The problem with the chopping techniques is that you need a better two-hand coordination. You can damage the anterior capsular rims, and you can get pieces stuck in what we call the jigsaw puzzle, wherein the pieces tend to mash into each other and don't get mobilized easily. So Dr. Paul Koch invented the technique of what he called stop and chop, which is something in the middle of divide and conquer and phaco chop, in which he split the nucleus into two halves, and then one stops doing more divide and conquer and then starts to chop each one of these pieces independently. So it requires less energy and pieces can be mobilized much better, and it reduces the chance of the chopper damaging the capsule as well. So here's a patient who has a posterior subcapsular cataract. As you can see, I'm not doing any hydrodissection here. I'm worried about the posterior capsule. It's a grade 2 nucleus. And what I always do is to try and create a little bit of a crater in the middle, because I like to delineate my rexus as well as create this crater to take the epinucleus and the cortex out of the way. And then I go into that initial groove or trenching, and as the stop and chop phacoemulsification conventionally has, you make one large groove in the center. I do tend to create a little bit of a side groove as well, because it helps the management of the nuclear pieces, because they become a little smaller in the center. You can keep going down, and then with your other hand you just crack it into two pieces, and then remember there is no hydrodissection here, so it's not always easy to mobilize this nucleus within that cortical bag rather than capsular bag. But with a little bit of work, without putting too much of stress on the zonules, you can mobilize it, because if you have a good hydrodelineation, you can do that. Thereafter, it's breaking up each one into two pieces here. We are doing a 4-quadrant breakup, and then each individual piece is then brought into the center of that crater-like area, where you can do either an in the bag or at best an iris plane phacoemulsification. We go on with this in the same fashion. We pretty much do a little bit of a chop. It's actually a mishmash between a real chopping maneuver and a slightly cracking maneuver. It's not a pure chopping maneuver. And you don't need to have a pure chopping maneuver, because once you've impaled the phaco tip into the piece, you can actually go in underneath the capsular rim and take these out. So that is one. And this is another video showing here the hydro procedures are being shown. The first one is the hydro dissection, where we are cleaving the capsule and the cortex, and the next is we're going deeper in and doing the hydrodelineation. You could see the two independent fluid waves moving backwards, and this is relatively easier to mobilize. It's a harder nucleus than the first one. This is a grade 2.5, and once you have the mobilization, we again go in and I create that little crater. This also tells me where my rexus edge is, because I don't use trypan glue in my patients routinely. And I go in with the probe, and I create my central trench and go down till, as Dr. Nosher very rightly said, the best depth is to see when the color changes in your red reflex at the bottom. And that's what tells you that you're at adequate depth for cracking. It's sometimes difficult to determine two tip depths, because tips are different. We use a 0.9 tip, people use a 1.2 tip. So 1.2 tip would mean a 2.4 depth. Here then again we put in our non-dominant hand. In this case it's a left hand, and we complete the crack, and you can see the brightness that comes up at the tip there, and that tells you that there's fairly adequate depth for you to crack. Classically, when Dr. Koch described his technique, he wanted the nucleus to get rotated 180 degrees and then crack the other end, whereas I just do it in one go. There's no need to rotate it at 180 degrees to do the other end. You can just do it in one go. And here again, I'm using, since it's not very hard cataract, I can get away with just a 4-quadrant breakup. The annoying air bubble always pops up just at the point where you want to do all your work, and so one just aspirates that and simultaneously. Again, the same thing is repeated for the other half and completed in that fashion. Each piece is then aspirated or pulled out from underneath the bag, and one has to be careful here that one doesn't snag the epinucleus, because if you bring out the epinucleus, and you see what I do with my non-dominant hand, I ensure that I keep the epinucleus away, because I would like the epinucleus to continue to give me the protection for my posterior capsule, and this is how it just continues to work. The whole thing is aspirated, and here I remove my left hand to ensure that I have adequate depth. I can always replace this with a blunter instrument like a wire rotator or a Lester, and in case the epinucleus doesn't come into my port like I would like it, I take down the parameters drastically when I'm doing epinucleus aspiration. So there's very little phaco energy in there. It's mostly just all set on cortical aspiration settings. My third and last video here is a hypermature cataract, and so I've used trypan blue here. I've created a larger than normal rexus. I suspect this cataract to be a little harder than 2.5. It's probably around 3. And here, after doing the hydrodissection, again I aspirate that central portion, gives me better visibility, as well as takes away whatever little epinucleus is in front of the nucleus. And then I again create my grooves. I'm still not using coaxial illumination. I don't need it at this point. I just have 3 additional reflexes to deal with. So I put it on only when I am in a position that I really need the red reflex. I keep going down into the crater as much as possible, and then I crack the nucleus into 2, and now you can see the lights have increased so that you can see at the time of the cracking that you've gone full thickness. These are not always easy, because if the cortex is not completely milky, they don't rotate easily. That the swollen cortex actually impedes the rotation. And here we again, it's a crumbly kind of nucleus, so one can't be, you have to take the parameters down. A little bit of adjustments has to be done on the flow rates and the vacuums, and so that one can individualize the phacoemulsification to the case. Here you can see that it didn't actually crack in an exact half. It was like a 2/5, 3/5. So one doesn't have to be in a 4-quadrant mode. One can make it into 5 pieces or 6 for that matter. So whatever is necessary, and always my personal preference is to go for the piece where there's another piece lying in front of it. What that does is, if there is a surge, you'll have the protection of the other piece coming forward rather than to have the capsule coming into your port. This is the stage which is the most tricky. You must usually bring down your parameters at this stage, keep the bottle height up, but reduce the vacuum as well as the aspiration rates, so that you can get you don't get too much of surge and have the posterior capsule coming in. The last piece invariably is the trickiest piece. So that was the removal of the last piece, and this is just a study that I recently saw as recently as 4 months ago, published in the JCRS from Park's group, where they compared the 3 techniques, and they used grade 2 to 4 cataracts, which they randomly divided into 3 groups, and they looked at the US time, the mean CD, the cumulative dissipative energy, the use of BSS and the cell counts, etc., and they found significantly less ultrasound time and energies and BSS used with the chopping techniques than with divide and conquer and stop and chop. The endothelial cell loss was also significantly lower in the phaco chop group. So obviously in experienced hands, chopping cuts down the time and the energy that one delivers in the eye. Thank you so much for your attention.